This meeting is about the lessons from Canada. And recently, the Canadian government were taking evidence from clinicians in Canada about palliative care and psychiatry and the law. And we were very impressed with listening to that. So thought that it would be very helpful to ask some of those presenters to present today to us the evidence that they gave to the government in Canada. I'm going to start off with Dr. Leonie Herx, who is a palliative care consultant in Kingston, Ontario. She's Associate Professor and Division Head of Palliative Medicine at Queen's University and the Medical Director for Palliative Care at Kingston Health Sciences Centre and Providence Care Hospital. She is Chair of the Royal College Specialty Committee for Palliative Medicine and a past President of the Canadian Society of Palliative Care Clinicians. So I hope that we will have Leonie coming up on screen now, and we'll be able to hand over to Leonie.
Okay, perfect. I think we're in business. Thank you. Good evening. I really appreciate the opportunity to speak on lessons from Canada, evidence from palliative care as it relates to our medical assistance in dying legislation and its implementation. Palliative care is a holistic approach to care that focuses on enhancing the quality of life for persons living with life-threatening illnesses and their families by means of early identification, impeccable assessment and treatment of symptoms, including physical, psychological, and spiritual concerns, and supports a person in living well until they die, medical assistance in living, or MAIL, if you will. Palliative care does not hasten death and is internationally recognized as a practice distinct from MAID, philosophically, clinically, and legally. Only about 30 to 50% of Canadians who need it have access to some kind of palliative care of unknown quality, and very few, only about 15%, have access to specialist palliative care to address more complex issues. You are less likely to receive palliative care if you are poor, Indigenous, homeless, incarcerated, or live in a rural area. Studies from around the world have shown that early integration of palliative care improves quality of life, reduced anxiety and depression, reduces caregiver distress, and may even help people live longer. An integrated palliative approach to care should be provided as part of the management of all serious illness starting soon after diagnosis. However, due to the ongoing stigmatization and misunderstanding of palliative care as end-of-life care, we are often only involved much later. When patients' palliative care needs are not met, the ensuing physical, emotional, and spiritual suffering can lead them to feeling depressed, hopeless, and a burden to others. Many of the factors driving requests for MAID. Earlier palliative care can alleviate suffering before it becomes irremediable. Failure to do so, as asserted by my palliative medicine colleague, Dr. Romaine Gallagher, should be seen as a medical error. Medical assistance in dying, or MAID, was established for exceptional circumstances, not as a routine procedure for ending life, as a solution to suffering that could be addressed through health and social supports that help people live a dignified life. Since MAID was expanded in 2021 to those with chronic illness or disability, we are seeing many cases in the media and in our own medical practices of people requesting and receiving MAID due to a lack of basic supports needed for living, including lack of palliative care, home care, and disability care. With the expansion to mental illness as a sole condition planned for March 2023, this is going to exponentially increase. Health Canada's latest annual report on MAID from 2020 shows that a significant number of people receiving MAID had no palliative care at all, 15%, or palliative care much too late. That includes 18% within 2 weeks of the MAID request, most likely prompted by the request itself, and 19% within 4 weeks. 3% were unknown. So that gives at least 35% of those receiving MAID who had little to no palliative care. This is consistent with a study by my palliative medicine colleague, Dr. Monroe, in 2020 that showed 40% of patients had no palliative care prior to requesting MAID in her region. This should be seen as a failure of our healthcare system. The 2016 legislated safeguard of a 10-day reflection period prior to the MAID procedure was removed by Bill C7 in 2021 when MAID was expanded in Canada. This allows for a patient to request and receive MAID on the same day. and this is likely to result in an even larger number of people having no opportunity to receive palliative care. In the landmark Carter versus Canada case that led to decriminalization of physician-assisted death in Canada, the Supreme Court of Canada discussed what possible impacts implementing a law for assisted death prior to securing universal access to palliative care might have on the development of a strong palliative care system. But they ultimately determined that few conclusions could be reached, and they even suggested that the MAID legislation itself could be used to leverage improved access to palliative care. We now have 6 years of lived experience with MAID, and that has not been our reality. MAID implementation has resulted in significant deleterious effects on palliative care, including diminished palliative care resources, replacement of palliative care with MAID, and increasing distress experienced by palliative care clinicians. I'll share some examples. Some health authorities incorporated MAID into their, quote, palliative and end-of-life care programs. This has led to palliative nurses leaving their jobs because they felt unable to provide the palliative care that they were hired to do. In Alberta, British Columbia, and Ontario, some hospice palliative care nurse practitioners and physicians used their time in paid palliative care roles to provide MAID at the direction of the health system administrators. In Ontario, Canada's most populous province, doctors providing MAID must use palliative care codes to capture and bill for their MAID work at the direction of the Ministry of Health, despite strong advocacy against this from the palliative care medical associations. Sadly, use of these palliative care codes then makes MAID providers eligible for a special premium meant to incentivize doctors to provide palliative care. Palliative care clinicians not involved in MAID are finding themselves spending increasing amounts of time on matters related to MAID, reducing their ability to provide palliative care. There is decreased access to specialized palliative care beds when health authorities require hospices and palliative care units to admit patients for the sole purposes of administering MAID. And we see increasing moral distress in palliative care clinicians from forced participation in MAID due to some health authorities mandating that MAID be provided in their hospices and palliative care units or lose funding. This has resulted in retention difficulties and early retirements from palliative care, which is accentuating and accelerating the already critical shortage of specialist and primary palliative care physicians. We also see patients unwilling to access palliative care services because they associate it with MAID and are afraid palliative care will hasten their death, or MAID might be provided without their consent. We see patients accessing MAID due to a lack of palliative care provision, patients requesting palliative care and the MAID team being sent, and patients requesting MAID because a trusted physician suggested it to them. Access to high-quality palliative care must be a universal healthcare right. Currently, Canadians have a right to medical assistance in dying, but not medical assistance in living. Thank you.
Thank you very much, Leonie, for a very precise, concise presentation. I'm going to go straight on to the next presentation, and Leonie very generously has said that she can stay on to be on the panel at the end. Our next presenter is Dr. Harvey Chochinov. He's a Distinguished Professor of Psychiatry at the University of Manitoba, former chair of the external panel on options for a legislative response to Carter versus Canada, and a long-time researcher and clinician who's published extensively on psychological matters pertaining to palliative care, and who also is one of the international advisors to the Cicely Saunders Institute here at King's College London. So Harvey, can I welcome you to the stage, a virtual stage, and ask you to share your presentation with us. Thank you.
So I would like to take the next few minutes to basically provide you with 5 concise points that I think are worth considering. The first is that there are some studies, both in Canada and the United States, that would imply that medical aid in dying is for the so-called white, wealthy, and worried. In other words, these studies suggest that we don't need to be concerned that people seeking a hastened death are vulnerable or disenfranchised, but rather are well positioned to make autonomous choices. This is a very narrow and problematic interpretation of the data. If we look at MAID deaths reported by Health Canada, most are elderly, fraught with various disabilities and comorbid medical conditions. On the other hand, the most significant concern about this data is that it pertains to patients with less than 6 months to live or whose death was reasonably foreseeable. So if we want to look at how vulnerability and hastened death will play out in Canada, we need to look at the Benelux countries or Switzerland where, like now in Canada, dying or approaching death is not a requirement. In Switzerland, assisted suicide is more common in women who suffer higher rates of clinical depression, those who are living alone, divorced, or without children. Loneliness and lack of social support are key vulnerabilities we can expect to play out in Canadian-made. 60% of patients who have received euthanasia for mental illness in the Netherlands are described as socially isolated and lonely. Like persons with disabilities, we also know that mental illness is associated with higher rates of poverty and lack of access to critical support services, food and housing security, things that can wear down the human spirit and undermine the desire and wherewithal to go on living. The next point. It is often claimed that whether you are dying, disabled, mentally ill, or chronically suffering, you are free to exercise your autonomy and choose whether you want to live or die. Now, if someone is standing on an open balcony in a high-rise apartment, rapidly being engulfed in hot flames, is it reasonable to say that they have a choice whether or not to jump? Exercising autonomy means having real and viable options. If you are dying in the absence of quality and available palliative care, if you're disabled but don't have access to supports and services or social, housing, and employment opportunities, if you have chronic pain or uncontrolled symptoms and you don't have timely access to a specialist, if you're struggling with mental illness and can't find a therapist prepared to help you grapple your way towards recovery, can we really say that you were exercising an autonomous choice? Did the 51-year-old Ontario woman with severe sensitivities to chemicals who chose MAID a few weeks ago after failing to find affordable housing free of contaminants really make an autonomous choice? Or did she just get tired of being seen as, quote, expendable trash, a complainer, and useless, close quote, and out of desperation jumped? Third point, individual or personal autonomy is like helium. Its nature is to expand and occupy whatever space it is given. Look at what's happening in Canada. We've removed reasonably foreseeable death and will soon include mental illness. And we are now contemplating children and advanced directives. If individual autonomy is the driver, and we observe what is happening with our European brethren, we will see MAID expand to include life completion and tiredness of life. 4, various palliative care researchers, myself included, are advancing the art and science of addressing suffering for patients with life-limiting and life-threatening conditions. Well, things like dignity therapy, developed by my group in Winnipeg, or others such as meaning-centered therapy or calm therapy, are not a panacea for suffering. They are proving to be effective in mitigating distress while enhancing end-of-life experience. And lastly, whatever direction Canada takes on MAID, it must first and foremost support the continued study and ongoing provision of palliative care. Fewer than 2 to 3% of Canadians will ever avail themselves of MAID. Yet nearly all Canadians living with a life-threatening or life-limiting illness could benefit from palliative care, even though only a minority will receive it. In instances when there aren't real choices, we must tread carefully into conversations about the right to jump and do all we can to douse the flames of human suffering across Canada. Thanks so much for this opportunity.
Thank you for such a concise presentation and given to us so clearly. Our next presenter is Dr. Sonny Gand, who's a professor in the Faculty of Medicine at the University of Toronto and Chief of Psychiatry at Humber River Hospital. And he clinically works as a psycho-oncology consultant. He's co-director of the U of T Adult Psychiatry and Health Systems Division and an honorary member of the World Psychiatric Association, and also past president of the Canadian Psychiatric Association. We're really honoured to have you with us, Dr. Sanigand, and I'd be delighted to hand over to you. Thank you.
Thank you so much for this opportunity to present. I'm just going to start the screen share. Okay, super. Thank you so much. And as others have mentioned, my distinguished colleagues as well, I'm honored to have this chance to speak with you today. My name is Sonugand, and I'm a professor at the University of Toronto and Chief of Psychiatry at Humber River Hospital. I've worked in psycho-oncology with dying patients and their families throughout my career. And I also sit as the physician chair of my hospital's medical assistants in dying, or MAID team. I'm speaking as an individual, not representing any particular group I work with. I don't bring any particular ideology to this issue other than advocating for evidence. I believe sensitive public policies like this demand a non-ideological, evidence-based approach. While I've seen the benefits of MAID in some situations, I've also been sensitized to the dangers of MAID in inappropriate ones. I've come to realize that Canada's rapid MAID expansion to non-dying disabled, and by 2023 to those suffering from sole mental illness, is a tale of two cities, two worlds actually. Our MAID expansion has been fueled by troubling myths and misconceptions. Chief amongst these is that expanded MAID is just about increased autonomy. Evidence shows that when death is foreseeable, people seek MAID to preserve dignity and autonomy, to avoid a painful death. Those seeking MAID in these situations tend to be, in the researchers' words, white, more educated, and more privileged. That has wrongly been used to suggest MAID is safe to expand to other situations. When expanded to the non-dying disabled for mental illness, that association completely flips. Then a different group gets made, the group of non-dying marginalized who have never had autonomy to live a life with dignity. Rather than death with dignity, they're seeking an escape from life suffering. And they do overlap with those who are suicidal in the traditional sense. Evidence shows this group is more marginalized, has unresolved psychosocial suffering like loneliness and isolation, and a terrifying gender gap emerges of twice as many women as men receiving psychiatric euthanasia. Worse, many of these people could have gotten better. Experts reviewing this, world-renowned CAMH, the Canadian Association for Suicide Prevention, and others have all concluded evidence shows we cannot predict irremediability of mental illness in any individual. If that's the case, introduced to help avoid painful deaths, MAID expansion provides these marginalized non-dying people death to escape painful lives. The so-called sunset clause in Canada mandated providing MAID for mental illness by 2023, but you cannot mandate manufacturing non-existent evidence. I wrote last February in The Conversation that in Canada's debate about medical assistance in dying, evidence has already been provided of medically assisted death. Our recent federal expert panel charged with providing guidance on how to implement MAID for mental illness remarkably concludes that no new safeguards are needed in legislation and fails to even provide any specific guidance on thresholds for establishing incurability or irreversibility before providing death for mental illness. That and the sunset clause is not how science works. No drug company is told their sleeping pill will be approved in 2 years without evidence of effectiveness or safety. The sunset clause is based on less evidence than required for introducing any sleeping pill, and the federal panel's guidance provides less guidelines than required to bake a cake. 2 members of the panel resigned over the course of the panel's work and did not sign off on the report. In bypassing the primary safeguard against premature death of getting MAID only when we can predict irremediability, any other so-called safeguards can be no more than false reassurances and lip service. While over 85% of Ontario psychiatrists in a recent survey supported MAID in some situations, less than 30% agreed with MAID for sole mental illness. And by a 3-to-1 margin, they opposed the sunset clause. A Quebec commission has now recommended against providing MAID for sole mental illness. Marginalized people in despair who could get better will and are getting MAID, leading to people literally saying, "I die when I run out of money," and to international headlines asking why Canada is euthanizing the poor. When asked about this recently, it was disturbing hearing our Prime Minister defend our country's MAID expansion in the House of Commons. As in this September 2021 piece in The Conversation, I think we are setting ourselves up for sadly needing to deliver a future national apology. You know, I grew up hearing the story of the Komagata Maru about those who were refused entry to Canada and sent back to India, some to their deaths. As a child, it showed me that the same policy, the Continuous Passage Act in that case, could ostensibly be the same for everyone, yet in actuality be racist towards some. I view our current MAID expansion the same way. That's the tale of two worlds. Same law, different impacts on different groups. It's a myth that expanded MAID is just about autonomy. The planned expansion in Sunset Clause may increase privileged autonomy for some to die with dignity, but it will do so by sacrificing other marginalized Canadians to premature deaths for escaping painful lives that society failed to allow them to live with dignity. That is not the Canada I grew up in. It saddens me we are descending to become the Canada where death becomes the answer for resolvable life suffering. Thank you for listening. I'd be happy to answer any questions later.
Thank you very much indeed, again, for a very clear, concise and evidence-based presentation drawing on history. And it is often said that if we want to know where we're going, we must understand where we've come from. And lessons from history should never be forgotten. You referred to Yanyit Su, and indeed we are delighted to have Yanyit Su as our next presenter. He is a DPhil candidate in international relations at Nuffield College and a stipendiary lecturer in politics at Pembroke College, Oxford. Before going to Oxford, he obtained a BA from McGill University in Canada, where he was an Alan Oliver Fellow and Moyes Scholar, and an MPhil from the University of Cambridge, where he was a Bacon Scholar. He certainly has a glittering academic career to date, and he's a Senior Research Fellow at the Judicial Power Project, hosted by Policy Exchange. I'm delighted to hand over to you, Jan.
Perfect. Thank you, Baroness Finlay, and thank you everyone for being here today. As Baroness Finlay has said, I'm not a doctor, I'm a political scientist, and today I'm going to discuss some of the legal and political implications of how we got to where we are today in Canada. I think it's fair to say that many people in the UK and elsewhere were shocked when they heard that Canada, one of the world's most progressive countries, was also a place where people felt the need to resort to MAID because of financial reasons. I think when MAID was first legalized in 2015, if you had said that this sort of headlines would become common in the space of a few years, you would have been accused of fear-mongering, of resorting to slippery slope arguments. And the point I want to make today is that slippery slopes actually do exist, and Canada is in a slippery slope, and that if we're not careful, the UK might find itself in the same situation as well. So how did we get to where we are today? So as many have pointed out, the ban on assisted suicide was struck down by the Supreme Court of Canada in 2015. Now, originally, they relied on the right to life, which is entrenched in Article 7 of the Canadian Charter of Rights and Freedoms as part of the Canadian Constitution, to justify tracking down this prohibition. Their argument was this: people who were terminally ill and who were worried that they could not die at a time and in a manner of their choosing could commit suicide prematurely. And because they could be pushed to commit suicide prematurely, the ban on assisted suicide was an infringement on the right to life, which was unconstitutional. Whether you think this argument is convincing or not is obviously open to question. I certainly do not think it was very convincing. At the time, the government, a conservative government, argued that a blanket ban on euthanasia was necessary to protect the vulnerable, the elderly, the poor, the mentally ill, and so on. And the court was shown evidence from Belgium and elsewhere that there was indeed a slippery slope where people were committing assisted suicide in circumstances which would be unacceptable at the time in Canada. And the court simply rejected, dismissed all this evidence. They basically said, we can regulate this moral hazard away. We can put into place a solid regulatory regime which coupled with criminal sanctions will make sure that abuses do not happen. And of course, that was wishful thinking. Parliament did enact what was at first a fairly strict legal regime for assisted suicide, where the person who was seeking aid had to, the person's death had to be reasonably foreseeable. Of course, that requirement was almost instantly challenged. And in 2019, a court in Quebec struck down that requirement as unconstitutional. The argument was that this infringed the right to equality of those who are not terminally ill, but who nevertheless wanted to put an end to their lives. And what is very interesting, that's the argument for MAID in the space of 3 years shifted from one based on the right to life to one based on autonomy and choice. And I think it is worth noting that the two plaintiffs in the Quebec case were sympathetic, middle class, educated. And I was talking to somebody who was involved with this case and who said that essentially the judge at first instance found it very difficult to say no to such sympathetic litigants. But of course, as we have heard, many people who resort to MAID and who are the most vulnerable and who are the most deserving and in need of society's protection are not like these litigants. And that is where we got to where today. As we have heard, Canada will soon have one of the world's most open-ended assisted dying regime. In 2023, those suffering from mental illness will be able to resort to MAID, and there's even talk of extending MAID to what are known euphemistically as mature children, the under 18. And perhaps not surprisingly, the tone of Canada's public discourse surrounding MAID has changed very dramatically. In 2013, the CBC, which is Canada's version of the BBC, was suggesting that if MAID was legalized, Canada would have improved palliative care as a result. As we have heard, this did not happen, quite the contrary. In 2022, a columnist in a national newspaper could say, in response to a story that a woman decided to put an end to her life because of economic reasons, that there's nothing that we can do to stop people from using a system such a system of MAID to make melodramatic statements about the poor quality of life. I think it's fair to say that in 2013, this would not be something that anybody would have felt possible to say in Canada in public discourse. This would have been seen, rightly so, as something unacceptable. But in 2022, this has been normalized. And so in terms of takeaways, essentially the limited legalization of euthanasia in 2016 has paved the way for its extension and abuse in Canada. And that is what really is known very often as the slippery slope fallacy. But what I want to point out is that the slippery slope can be a fallacy, but is not always a fallacy, because if you say making A legal makes A+1 more likely, that is not a fallacy, that is simply a description of how social political change happens. And that is in many ways where we are in Canada, and if we're not careful, that could be the future in the UK as well. Thank you very much, and I'm happy to take any questions you might have.
Thank you very much indeed, and again for a very precise presentation. And I wonder if we could now go over to having people on the panel, and so that we can take questions from the audience. I've got some questions that have come in already, and I think one that's come in from Air, which I think is really quite to the nub of all this, of the presentations, asks what proportion of people having MAID and dying with MAID have had a psychiatric assessment. I wonder whether Sonu and then Harvey would like to respond to that from the psychiatric point of view, and then possibly Leonie might want to comment. Sonu.
Oh, thank you. So in Canada, we don't have any statistics on that because it's not yet something that is officially being provided for sole mental illness. But when you look at the Benelux countries, there was a review done by Scott Kim and colleagues of all of the cases in the Netherlands between 2011 to 2014. And in that review, what they found, this was actually also one that found 70% predominance of women getting psychiatric euthanasia. But they found that while there were psychiatric consultations in most cases, about 11%, so 1 in 10, did not have a psychiatric assessment or psychiatric independent input in the process. And furthermore, they found that about a quarter of the cases involved disagreements between consultants, meaning that at least one consultant at some point thought, no, this person should not qualify for it, but they subsequently got another opinion that qualified them.
Thank you. That's very interesting data. And that's a review by Scott Kim that you were referring to.
Yes, it's in JAMA Psychiatry, April 2016.
2016, thank you. A useful reference. Harvey, do you have a comment on it?
Not much to add to what Sonu has said. Certainly my sense is that the extent to which psychiatric consultation is called into play is the minority. I believe there also was some data that was published by Health Canada, and you may want to look into their most recent report. I don't have it at my fingertips, but I somehow recall that the percentage was somehow, in the area of less than 5%. But you may want to check the Health Canada report, the most recent report on MAID. Perhaps either Sonu or maybe Leonie knows of the data and can point you towards that.
Leonie, do you have a comment?
No, just briefly to say that, of course, there's no requirement for formal consultation with a specialist, even under the track 2, which we call it for people that don't have a reasonably foreseeable death. The MAID provider, if they feel they have expertise in the condition, does not need to seek a formal consultation with another expert.
Yeah, thank you. And actually that figure of below 5% also fits with the data that's coming out from Oregon, where I think it's now below 2% have a psychiatric assessment, and the percentage has gone down over time. The next question that we've got coming in is from Francis, who's asking, in fact, possibly for Leonie, can you tell us anything about the inmate model? That's kind of new to me. So Leonie, I don't know if you have any information.
So in terms of medical assistance and dying being provided in prisons?
I think so.
Yeah, so the chief, I'm trying to remember his exact term, he's the head of overseeing medical practice within the prison system, wrote a report that was shared with the Senate last year during the C7 testimony that expressed significant concern that prisoners do not have any options for living in terms of choice about where they receive their care, access to health care, and that it was had significant concerns with MAID provision to prisoners. So I think we'd have to access I can send you the report that has the data regarding that, but certainly had very clear concerns about prisoners choosing MAID to get out of, they couldn't get parole, for example, or they had nowhere to live, couldn't find a placement in long-term care. So it is a big problem in the prison system.
I think the comment coming in is that he meant that in relation to palliative care, and how many people in palliative care would then go on to access MAID, or is palliative care being used as a stepping stone to MAID? That had been a problem in Belgium, I think, where they tried to put in a period where people had to have palliative care before they would be eligible, but that ended up being used as a way for people to queue jump to access palliative care, and sometimes it became quite difficult for clinicians because people basically didn't really want to engage in palliative care. It was a sense of having to. I wonder if you've got any comments on any experiences like that. Perhaps Leonie, who's the one at the front line in clinical practice.
Yeah, and I'm sure Harvey can speak to this as well, so maybe he can add afterwards, but there is no requirement for palliative care to have been provided. The legislation requires patients to be informed of all their options. And so many of us have argued that having information and having lived experience and truly having care that's accessible are not the same things. And as we've discussed earlier, most people in Canada do not have accessible, high-quality palliative care. So is it, as Dr. Chochinov said, truly informed consent to just have some information provided? And truly the information you receive about palliative care is only as good as the person giving it to you understands. And many clinicians do not understand palliative care and all that it has to offer. So there's those limitations as well. Perhaps Harvey wants to comment.
Harvey, you're on mute.
Just to follow up by saying that it's also troubling that the only information that's being collected with respect to palliative care for patients receiving MAID is exceedingly limited, essentially boiling down to, did this person receive palliative care? Then how long did they receive palliative care? And then the third thing is, was there a consultant brought in? And that's where, again, I will send you the copy of Health Canada. So when that kind of limited information is being collected and being used to support, this idea that MAID patients have great access to palliative care when the information being reported is limited and flawed is highly problematic.
Yeah, thank you. There is, yes, Sonu, please.
Oh, thank you very much. I just wanted to make one comment on a couple of the points that Leonie and Harvey have alluded to. And I think many people, at least outside Canada, and I know most in Canada, don't realize that we are unique in the world in not even having a requirement that any sort of care or treatment needs to have been provided. And we have a unique clause that says the relief of suffering needs to be by means acceptable to the patient. So it's purely subjective, and nobody's suggesting forcing treatment, it's not that. But every other jurisdiction, including the Benelux countries, does have additional requirements that say that the request needs to be well considered, needs to be in a medically futile condition, etc. In Canada, if somebody has not had access to treatment, or if in a state of depression and despair, they think nothing can help them, even though evidence may very well show it has in the past, then they can still apply and get MAID. And so that's another consideration quite unique to our laws that I think do make them the most liberal in the world.
So do you think that links to the privileged autonomy aspect that you were talking about? So that if somebody has very false beliefs about what medicine does, perhaps is needle phobic or whatever, and is wanting to reject everything, and has quite severe psychiatric illness perhaps, that in fact they can just refuse everything and then proceed straight to MAID. It feels as if that's a possibility within your law.
It's being left essentially at the subjective discretion of each individual assessor. There is no scientific evidence, nor even protocols or guidelines. The recent panel that issued its report that was supposed to provide guidance actually said that it's not possible to say the number or types of treatment that should be tried before. It's a case-by-case decision. And others have said, oh, it's basically an ethical decision, which is not a scientific one.
Mm. Another question coming in, which I think concerns quite a lot of doctors actually, is whether there have been complaints about doctors when they have either refused to be involved in MAID at all or refused to be involved in MAID on a particular patient, and whether those have reached the regulatory authorities in terms of being viewed as unprofessional. Perhaps Leonie, have you got any comments on that?
Yeah, so doctors are regulated in Canada by provincial colleges. So each of the provinces have slightly different rules on what the expectations for participation are within the MAID framework. So for example, in Ontario, you have to provide what's called an effective referral, and how that is being applied is interpreted differently by local hospitals, for example. So some people say you actually have to formally contact the MAID team yourself, whereas actually if you look at the policy, providing information that the patient can then self-access would be sufficient. So what I have seen, and I've had quite a number of colleagues come to me from across the country when I was in my president role for the National Specialty Society, to say that they are facing quite a lot of bullying and marginalization within their own institutions and organizations if they are not promoting MAID and bringing it up to patients even, and facilitating hooking the person up directly with the MAID team, which for some people feels like they're making a recommendation and supporting that for a patient when they might not think it's medically indicated or within their professional role. So there's actually quite a lot of bullying, to be frank, that's happening within institutions and regions about this. And I will add one more brief comment, is that if you express concerns about MAID, for example, you're worried this person might not have capacity to make the decision, we are being seen as trying to block access to MAID as opposed to advocating for patient safety and best clinical practice.
And relating to that, the questions come in about whether there have been any cases referred to the Canadian medical regulator in which it's been alleged that doctors were guilty of misconduct in allowing MAID. So whether complaints or whatever have come through, and if not, why do you think that is? Perhaps, yes, Sonu.
So in terms of ones that have gone fully through the court system, I'm not aware of any. So I'm not aware of any outcomes. There is a case out in BC that's under investigation, I understand, of a woman who was an actual former psychiatric nurse who had some medical adversity and was admitted to the hospital, and during that time got MAID, and her daughters were very upset because they felt she was also suffering from resolvable depression and got it for that. So that one is pending. And one thing I would also point out is that, following up on Leonie's comments, I think, Yuan, you were absolutely right in how this can reflect a change in social expectations, because our current statistics from 2020, which is before our recent expansion, this was when death needed to be reasonably foreseeable. Those statistics showed that in 5 short years, 2.5% of all Canadians were dying by MAID. So 2.5% of all Canadian deaths in the country 2 years ago were by MAID, and the number goes up each year. That's before expansion. And some regions had much higher, 7 up to even 10, approaching 10%. And quite strikingly to me, in our recent parliamentary consultations, some of those advocating for further expansion of MAID have said the problem with those numbers is that some regions are lower than others, and that must reflect people are not getting adequate access or informed consent, and have advocated that anytime someone's admitted to hospital, if they might be eligible for MAID, the medical practitioners should have an obligation to tell them they might be eligible for MAID. And that could apply to any non-dying disabled person at this point.
And
yeah, Harvey, go on.
No, I was just going to say that while Sonia was speaking, I also had a chance to look at the Health Canada report, and indeed the prevalence of referral to psychiatry is 5%.
Thank you. And actually, in a moment, I'm going to go to a comment that's come in from somebody typed up, and I'll read that out. But Jan, I wonder whether you feel that what this represents is not a so-called slippery slope, but actually you could call it a precipice, or you could call it a dramatic change, whereby MAID is becoming viewed as the default way to die if you think that you might be dying, even if you're not necessarily really dying yet. And whether there's some reflection in there about society's whole attitude to death, dying, and the need to care for its citizens at a difficult time in their lives.
Yes, yes. I think precipice is probably right. Right. A slippery slope refers to the mechanism, but the social changes we have seen over the space of 7 years have been dramatic. Dr. Gain has referred to the preponderance of people resorting to MAID in cases which would have been, I think, even a few years ago, would have been really more or less unthinkable. In terms of the broader societal picture, I think there's a lesson to be learned here, because I think Canada, on the one hand, is a country which always views itself, we self-consciously view ourselves as a liberal, progressive country. And sometimes, sometimes that will inevitably obscure the reality of what is being done. I have heard people very well-educated, reasonable people say the most horrifying things in terms of what are our duties to our neighbors, to our fellow citizens, what is society's duty towards third parties who are vulnerable. And essentially people, and a surprising number of people actually will justify what's happening. If you read the Canadian press, people are openly saying things like, why should we pay for those people to live? We're already paying them. There is something quite extraordinary happening. It's very hard to describe what it is because we're living in the middle of it. But I think the point here is these changes can happen very quickly. And finally, just one last point. The UK and Canada, in many ways, are very similar countries. And very often, things which, developments which happen in Canada tend to come to the UK after a couple of years delay. So it's not a case of Canada being exceptional. What's really scary to me is that Canada is a normal country, but a normal country with normal people, and where this has been normalized. And this is also a risk for other countries, such as the UK.
Thank you, Jan. Very important comments indeed, and somewhat prophetic, I think. There are two comments here, which one I'm going to read out, and one is a question. I'm going to put them together. So David Henderson asked, can we comment on the push to change from a request for MAID having to be initiated by the patient to MAID being discussed as an option without provocation? And I'll come back to that in just a moment, because Jose Pereira has just also written, I'm Dr. Jose Pereira, Professor of Palliative Care at McMaster University in Hamilton, Canada, from 2020 to 2021. I worked in our regional palliative care unit. Some patients were transferred from other units in the hospital and affiliated hospitals in the region to receive MAID. I and some colleagues experienced some situations where, when we tried to apply palliative care interventions, such as dignity-focused care for those persons, we were left to feel that we were being obstructive. I've heard proponents of MAID in Canada saying that many patients who request MAID are already in palliative care units. However, those statistics do not capture these cases when we feel blocked and distressed of not being able to really provide good palliative care. So that was a comment that came in rather than it. I wonder if I can go back to you on the panel though, about that comment about it being discussed as an option without provocation, rather than it formally having to be initiated by the patient. And my understanding was initially it had to be initiated by the patient. Who would like to take that? Perhaps Harvey, given the comments about dignity enhancing care as well that came in from Jose Pereira.
Yeah. One can be of two minds. On the one hand, I have heard people say that, because this is a patient right, and I heard this actually argued by some of the people giving testimony at the recent presentation to the Canadian Joint Committee, is that patients should know all of the options that are available to them in order to give valid consent. On the other hand, and again, thinking in terms of being a psychiatrist and thinking of the therapeutic work that I do with patients, I can't help feel that it's kind of emotionally tone deaf for us to be obliged to introduce the notion of assisted death at the time that a patient is expressing that, they're feeling so dreadful that they no longer want to be alive. A wonderful colleague of mine and a very senior, well-respected palliative care clinician and leader in this country, Mike Harlos, wrote a wonderful piece that's published on the Canadian Virtual Hospice called, I think, Sit Down and Lean In. And basically, the point that he makes is that, the idea of not wanting to be alive is something that is part of palliative care. Patients, reach this point in their lives where they start to question, is it worth going on? And we need to have the skills as clinicians to be able to sit down and lean in and to try and understand what the sources of their despair and what the sources of their anguish are. And the other thing, just sort of in closing, that I shared with one of the members of Parliament as I was being questioned on this, we need to be very cautious about the idea that, the only card in our deck is assisted death. We need to bear in mind that there are multiple ways of addressing end-of-life distress. I mean, I have the great honor and pleasure of being one of the editors on the textbook, the Handbook of Psychiatry and Palliative Medicine. It'll be coming out in its third edition later this year. And the point is that there are a multitude of authors with over nearly 50 chapters from around the world. In other words, there is an international community of clinicians and researchers who are devoting their careers to looking at ways of mitigating distress towards the end of life. That is the essence of what palliative care and palliative medicine is about. So, you know, I'm reminded of a quotation by H.L. Mencken that I was looking for the right place to introduce, and perhaps this is the right place. And that is, he said, you know, for every complex problem, there is an answer that is clear, simple, and wrong.
Thank you. And I think that takes us very neatly into that. We've just got time, I think, for a last comment here, which is a question which probably goes to the nub of the whole thing. Why does MAID require doctors? Because what you're all describing is a conflict between the provision of medical and clinical care and possibly a failure of adequate assessment of the options. So would it be safer or less safe to say this is nothing to do with medicine and you put it as a completely separate service outside? And I'm reminded that when we look at the ratings of quality of palliative care provision around the world, the only place where it isn't part of the main medical provision when it's been legalized to Switzerland, and the quality of their palliative care has gone up. But in all the other countries, the ratings seem to show a deterioration. So picking up on the comment perhaps early on that all the countries have good palliative care, I think that might be slipping into the past tense, perhaps. I'm not sure. I don't want to denigrate the efforts of anyone on this call, but anyone got any comments about doctors and possibly this having nothing to do with doctors? Jan, perhaps I could ask you first.
Speaking as a layman, I was thinking about this. In America, when death penalty is administered through lethal injections, it's very sanitized and so always doctors involved. And of course, you know, you don't really need that. But I think, again, from a layman's point of view, having a doctor, somebody who is trusted, authority figure, perhaps makes the whole thing seem more reassuring to the general public. It makes it seem more safe, more regulated. And it's also a thing which I think I picked up from what others also have said on this call, is that it seems that there is, that it seems to me that if you put palliative care and MAID in the same system, inevitably there's going to be intra-medicine competition for resources, which is a sort of fairly standard bureaucratic process. So maybe there is something here as well, but I'm curious to speak as a layman and be very interested to hear.
Thank you, Jan. Shall I go to Leonie and then to the other two? Thank you.
Yeah, I mean, back in 2016 or 2015, after the Carter case, many leading physicians and bioethicists did say that this was in direct conflict with the role of the physician. And as I've explained, the direct conflict with palliative care as well. But what patients have told us, and I think this is important, I've heard directly from many patients, is that some of them have actually requested MAID because their trusted clinician, their thoracic surgeon or their oncologist or their family doctor suggested MAID as an option to them. So they already had a fear of what future suffering might be like. And now they're like, oh my gosh, my doctor has said I'd be better off getting MAID. So then they request it. So I actually have seen the reality of this impact on patients, that they see it as then a recommendation from a physician, and it becomes a very procedural process, which in itself is dangerous.
Thank you. Sonu and then Harvey.
Thank you. And, you know, this touches on so many things. I don't have an answer for whether it should or should not necessarily be in the House of Medicine. What I can say is that the way it is currently framed is not an honest framing of what the House of Medicine is doing, because what we have been asked and tasked to do is to say, these people can and should qualify for MAID for an irremediable medical condition, a medical condition that won't get better. And what that does is it provides a false reassurance. So in addition to the authority that comes with that, there's a sanitization and I would say a lack of intellectual integrity in what we're actually providing MAID for. And so I think it's dangerous to provide death for one reason while we're ostensibly saying it's for a different one that we can't even predict. And, you know, I'm reminded of the words of Dame Cicely Saunders, right? I mean, she talks about how pain and total pain is about our cumulative suffering. And what now medicine is being asked to do is be an arbiter of, well, what level of total suffering should society provide you easier access to death for? This is a very troubling question.
Harvey, 1 minute for you, and then I'm going to finish up with a comment that's come in from someone in the audience.
I guess I would just sort of take us back to, I mean, you know, what is the role of medicine to alleviate suffering? If we think about the number of people, and it's just sort of being quite kind of mercenary about this, I mean, the number of people who will avail themselves of MAID, or if we look at a place like Oregon, where less than 0.5% of people who are dying actually avail themselves of assisted suicide. The fact is that, you know, 90% or more of people who have an expected death can benefit from palliative care. So if the intent of all of this, you know, whether you're for or against MAID, if the intent of all of this is to try and address universal suffering, then we really need to focus on the vast majority of people who will benefit from quality, comprehensive, accessible end-of-life care, palliative care.
Thank you. And I think I'm going to finish up with a comment because that's come in from David Henderson, who says, if the equal energy that has been put into advancing MAID in Canada was put into advancing palliative care, we would be much further ahead. And I think that probably contributes in a very concise way to that important question about, is this something that belongs in medicine, or actually should it be something that has nothing, that is completely outside medicine and is provided by an alternative group in society, if that's the route that society wants to go down? Because in the past we have had executioners for judicial execution, we have soldiers, we have all kinds of people, but the role of doctors seems to be meant to be different sometimes. And in the current climate, of course, we've seen the importance of the neutrality of the doctor in treating the wounded in the war that we're currently watching from abroad. It's an aside comment, really, but I think that that was a very important question and an important comment. I'd like to thank you all very much indeed for superb presentations, which we will be putting up on the website, and also thank all the attendees who've joined us and put questions in. We will be putting on another all-party parliamentary group for Dying Well before too long. We'll publicise the date to people when we get there. In the meantime, thank you all, and I hope everyone stays safe. Thank you.